So come on up front. There are lots of places to fill in up here. We'd like it to look like we've got a big crowd here when we put the video up. Hopefully our docs will be here soon. Ah, here they come. Come on up front. Lots of seats.
Switch them around. I want Ernst to sit next to me.
I'm at the end.
Yeah, okay, I'm good.
While we're waiting for everybody to get settled in, maybe I can remind folks to turn off your cell phones, please, or put them on silent or whatever. Would you please?
save some more? All right. We should have a chat.
Yeah.
I don't want any.
That's right.
Sure, when do I?
Yeah, I got you. Not a problem.
And I should hear from your side.
Yeah, cool. I appreciate it. We're good. Okay. All right, we're going to get underway, if I can get your attention. This is the medical panel. Members up here are members of our medical advisory board, and this is an opportunity for you to hear from them as to what research they're involved in, how they got interested in myositis research, and it's really an update on the state of research currently around this disease. There's going to be opportunities for you to ask questions. We're going to let the members of the panel first say a few words. Each of them has been asked to only spend 2 or 3 minutes describing their career and their interest in myositis. So really it's designed to not just inform you, but also give you a chance to ask questions of them. I'm going to turn this over to TMA's research director, Linda Cobert, but before I do, I just want to make a point to you that members of our medical advisory board, and there are 20 health professionals who are members of the board, are not compensated by TMA. They volunteer their time. They're volunteering their time here at the conference. They also, many of you probably know, they see a lot of myositis patients. They do lectures on behalf of TMA, what are called grand rounds of medical schools, and informing medical students about myositis and hopefully getting members of young investigators interested in this disease. They do a lot of good work for us. They're ambassadors for TMA, and I just want to acknowledge that, and I'd like everybody to join me in a round of applause of appreciation. And they're all very nice people too, which is kind of amazing. They're good. They're great physicians. So I'm going to turn it over to Linda, and you'll have your chance to ask questions shortly.
Thank you, Bob, and welcome everybody. How's everybody doing today? Yeah. So I am going to invite the members of our medical advisory board to introduce themselves. We'll start over here, and just tell us who you are, and I would like you to share just a few words about how you got interested in myositis as a disease and taking care of patients who have myositis. If you could just say a few words about that.
So I'm an elected one, I get to go first. So my name is Rohit Agarwal. I work at Ohio State. I'm a rheumatologist, and I see patients, I do research, I teach medical students, try to get more people interested in science and research, and especially myositis. I got interested in myositis because of a patient I took care of, maybe about now 16, 17 years ago. Obviously, I went into medicine because I love taking care of patients, but then there are patients that really, really make an impression on a physician that they will never, and should never forget. So this patient was a teacher, a wonderful woman, full of life, and very, very quickly, in the span of a year and a half before she came to see me, was sort of transformed in a bad way from being a highly functioning woman to a very, very disabled woman because no one knew what was going on with her. She had a statin-induced myopathy, and basically we made the diagnosis, tried to help her, but she was just a fighter, and she definitely left an impression that on me that got me started to study myositis in the laboratory. I previously focused all my attention on lupus, and so we started studying it, and we've been studying myositis ever since. So again, we are grateful for these experiences. We are grateful for all of our patients and all the lessons they teach us. So thank you.
My name is Namita Goyal. I'm at UC Irvine. I'm a neurologist, neuromuscular specialist there. I first got really interested in inclusion body myositis when I was in Boston, and I worked on the bimagrumab Novartis, the first clinical trial, and I saw the great unmet need for treatment in IBM patients. I was really just struck how patients came out of the woodworks, and I realized there's really no great drug out there for IBM. I worked with Dr. Greenberg and Dr. Amato there, and then when I moved to California 5 years ago, I continued my efforts, and I've sort of focused on 3 aspects of myositis. Improving the diagnostic odyssey that many of you have to go through in getting the correct diagnosis and management for myositis. Number 2, I became interested in the NT5C1A antibody that was recently found in IBM and why patients have it and why other patients don't. So we did a small study looking at if there is a clinical difference between patients that have the antibody or not, and we're working at looking at that further. And then number 3 is just clinical trials in myositis. I do think it's really important to look at other treatment options and better clinical trials for our patients with inclusion body myositis, dermatomyositis, all of the myositis. So I spend a majority of my time in that avenue as well. Thank you.
Hello, hi. I'm Sue Maylard. I'm a specialist physiotherapist from London in the UK. But my specialty is actually young people with myositis, so under the age of 18, because I work at a pediatric hospital. And I guess like lots of us, we all have that one patient that made a difference to the way we thought about how we practiced. And mine was particularly related to a young lad who had juvenile dermatomyositis. And at the time, the recommendation was that we should not exercise when you have active disease. So they allowed this young lad to lie in bed for 1 year. I know. And then handed him to me when the doctors deemed that his disease was under control and said, now you make him better. So they had got his disease under control, but they hadn't given him any life. So it took me a year, but between the two of us, we got him back functioning, walking independently, back discharged, back to school full-time, and he was working on getting back into school and, you know, back into sport and things. And it made me really think that actually, why did we do this? What was the evidence? And when we looked into the evidence about not exercising, it was not really substantial. So I researched and found that exercise was safe for young people with active disease and inactive disease. And in fact, with our training program, often were stronger than the healthy controls I used in my research. So from a pediatric point of view, we changed our philosophies very quickly to actually starting exercise as soon as the disease is diagnosed. And within that whole philosophy, the unit I work in, we look at how to make good diagnoses, fast diagnoses in young people, and then how to provide intensive treatment very early on in their disease process, because they're growing and they're developing, and we want to limit the damage the disease does at that stage in their life, in order to make sure that they get a childhood and they get an option for whatever they want to do in their adulthood. And I guess in my enthusiasm of helping young people, what I've really learned from being part of the TMA is I think that lots of those principles are entirely relevant for older young people, and that's for you. And you know, and I think always looking to what you can do next for me is the most important thing. And if I can impart confidence in you being able to have some control over your bodies again and actually having some ability to improve and get to your next goal, then that's what I'm here for. So thank you.
Let me see if this microphone works. Okay. Hi, everyone. My name is Tom Lloyd. I'm a neurologist at Johns Hopkins. And I first became interested in myositis, in particular IBM, when I was a resident and fellow. It was right when Amy Mammon and Lisa Christopher Stein had first actually started the Myositis Center at Johns Hopkins. And as a neuromuscular fellow, it was really my job to actually read all the muscle biopsies. And it was year number 1, I think, of their Myositis Center. And at that time, literally they had a flood of muscle biopsies from outside places that were actually being sent. So the number of muscle biopsies grew from right around 250 per year to almost 500, and I was the only fellow that year, whereas prior years there were always either 2 or 3. So initially I became really interested from actually my background research was in ALS, and as I was looking at these inclusions in muscle biopsies and others, including Chris Weil here, had clearly showed that these aggregates, these inclusions in IBM, have actually some of the same actual proteins in the muscle as is present in motor nerve cells in ALS, that it really became extremely interesting to me in trying to understand how this disease actually comes about. And so that was my initial interest. And then it was really in seeing patients. So over the last 10 years, I've really focused on taking care of inclusion body myositis patients. And over that time, it's really been you all with this disease and hearing your stories and the lack of effective treatments that has really inspired me and motivated me to really work to help and find treatments. And so my lab works to actually make better models of inclusion body myositis, and then and we're also involved in clinical trials in IBM.
Good morning. My name is Florian Ernst. I work at Mayo Clinic in Rochester. I'm an adult rheumatologist. I got my interest in myositis when I was a resident in internal medicine. And I actually worked with Dr. Reid, and we worked on an epidemiological study on inclusion body myositis. And so I helped to count all the people in Olmsted County who had inclusion body myositis, and then from there my interest expanded to dermatomyositis and polymyositis, and I've been involved in a couple of research trials over the years. I've had a lot of experience with teaching medical students, and I'm the program director at Mayo Clinic for the Rheumatology Fellowship. So I'm involved in teaching the younger generations, if you will, about how to assess patients who have myositis. I've also worked with Dr. Alexanderson in helping to develop tools to measure your fatigue and your stamina and endurance in the clinic. And so I am grateful to be here and to see all your faces. Thank you very much.
Good morning, everyone. My name is Mazen De Marchi. I'm a neurologist from the University of Kansas Medical Center. But prior to that, many moons ago, I graduated in 1988 from the American University of Beirut in Beirut, Lebanon. With my medical degree, did my training at the University of Texas, Houston Medical School in neurology, then fellowship in neuromuscular medicine and electromyography. And since then, I was on faculty first at the University of Texas, Houston, for 12 years, and the last decade at University of Kansas Medical Center. In Houston, I collaborated closely with our partners, rheumatologists, that had a strength in myositis. Always was interested in it since part of my fellowship training included doing muscle biopsies, looking at muscle biopsies, something that I've continued doing over the years. And we collaborated on different research ideas. HIV and myositis was one idea. The other idea was gene expression profiling in people with polymyositis and dermatomyositis. When I joined KU, now in 2007, more than 10 years ago, okay, something important is about to be said. That's why the feedback. But anyways, when I joined KU at the time, I saw the strength in clinical trials, and we used to have a number of about a dozen clinical trials. Since that time, in the last decade, we grew that by 5 times. Clearly, myositis is near and dear to my heart, whether it's inclusion body myositis, whether it is polymyositis, dermatomyositis, or necrotizing autoimmune myopathy. So we're on the front line of collaborating with investigators who are interested in conducting trials effectively, as well as creating our own innovative research programs. So thank you for being here.
Thank you. My name is Marianne de Visser. I'm an adult neurologist from Amsterdam. I work at the Academic Medical Center in Amsterdam, the Netherlands. I became interested in myositis when I was able to go to the Mayo Clinic to work with Dr. Andrew Engel as a young neurologist, so that's a while ago. He assigned me the task of doing research on muscle biopsies of patients with dermatomyositis. Later, I was inspired by the unmet needs of patients. We can do much better finding better therapies, but also I noticed how many patients were misdiagnosed. So my research focuses on participating and initiating trials in patients with dermatomyositis and polymyositis, but also on improving the diagnostic armamentarium, in particular the muscle biopsy and muscle imaging. Thank you.
Good morning. My name is Chris Weil. I'm at Washington University in St. Louis. I'm a neuromuscular physician. I consider myself a physician scientist, so I have a basic science lab as well as caring for patients in the clinic. My background's in mechanisms of neurodegeneration when I was doing research as a PhD student, and then began caring for patients and realizing the overlap between neurodegeneration and the muscle degeneration that happens in inclusion body myositis as well as other muscle diseases. My laboratory focuses on the genetics of inclusion body myositis. We also are interested in understanding novel biomarkers of inclusion body myositis, understanding why myositis occurs and leads to muscle degeneration. And more recently, after spending years thinking about how these things occur, I'm thinking now more about how to translate that into actual patient care. And in order to do that, understanding the unmet need and understanding both biomarkers of how we can understand if a patient improves, so not just if they improve with strength, but if they improve with certain markers in their blood as well as markers in their muscle, and whether we can use that to correlate. So overall, I've become much more interested in thinking about how this applies to patient care as well as to patient treatment trials. And so my future career plans to emphasize more on how we can start translating some of these basic science questions actually into therapies and ultimately into therapeutic treatments. So thank you.
All right, hi, my name's Andy Mammon. I'm a neurologist. I'm at the National Institutes of Health, but I started out at Johns Hopkins, as Tom said. I was also a neuromuscular fellow before we started the Myositis Center, but I also kind of became interested in myositis during my fellowship. There we would see patients in the clinic as fellows with the attending physician, some of whom had myositis, and then we would actually go to the operating room and perform or help perform the muscle biopsies, and then we would actually go and look at those muscle biopsies under the microscope. And like Tom, I was fascinated by the muscle biopsies in the patients, and soon realized that there's not very much known about these diseases, and not much known about either inclusion body myositis or the autoimmune myopathies like polymyositis and dermatomyositis. And really there was no group at Hopkins that was focusing on seeing these patients. I also realized that this was really a multi-system disease for many people. And I wound up getting together with a rheumatologist, Lisa Christopher Stein, and a pulmonologist, Sonia Danoff. And so we just started this multidisciplinary clinic at Johns Hopkins to see patients who have inclusion body myositis and other forms of myositis. And we've been able to really accumulate a large number of patients. And, you know, based on the work that other people have, you know, had done before we even showed up on the scene, we became very interested in the idea that myositis was not really, you know, one or even 3 or 4 different diseases, but lots of different diseases. And one of our ideas has been that the myositis autoantibodies can really define distinct subpopulations of patients with myositis. And we're very interested in the idea of trying to understand whether those or other biomarkers can distinguish distinct populations of patients who have diseases that may respond to different treatments. And so our goal is to really understand the different forms of muscle disease, what may trigger them, including environmental triggers such as statins. And really our ultimate goal, of course, is to bring that all back to patients and hopefully be able to provide more effective and better tolerated treatments.
My name is Naga Raju. I am at the State University of New York at Binghamton. So I have a little weird background. I'm a veterinarian and an immunologist.
Dogs get their
yes. So some 2 decades back, I joined Dr. Paul Plott's lab at NIH, and he told me at the time, you know, Raju, you're interested in a disease for which cause is not known. Myositis is the disease that you want to focus on. And very early on, I realized, you know, he told me, you know, you are a veterinarian, and I think probably we need to have animal models to study myositis. So can you make a model to study myositis? And I asked Dr. Plotz, you know, we don't know what causes myositis. How can I make a model for myositis? He said, yes, the best way is to look at a lot of biopsies and figure out what proteins or what molecules are abnormal, and test one by one which of them can cause similar muscle weakness, muscle inflammation in myositis model. So that effort ended up creating a model that at least helped us to understand why our own immune system tries and damages our own muscle cells. So I spent last 2 decades working especially with the very early on the funding that I received from the Myositis Association helped me to stay in the field, because as you all know, if you're a researcher, it's very hard to find funds for rare diseases. Everybody is interested in famous diseases because that's where a lot of resources are. And that's why I have to specifically thank TMA for engaging me some 2 decades back to focus on myositis. And part of the credit also goes to my mentor, Dr. Paul Plottz, who has been there for me to focus on myositis. So during the course of these studies, I became extremely interested in why glucocorticoids work, and many of them have so many terrible side effects. Almost all of you know what they are, side effects. So in collaboration with two of my colleagues, so we created analogs that only has beneficial effects but not the side effects. So that particular drug it's not a drug, still it is a compound called vamorolone. So it is currently in human clinical trial in children with Duchenne's muscular dystrophy. So the clinical trials are done 3 stages: safety and efficacy. Efficacy in a small group and efficacy in a large group. Right now, we are testing the efficacy in these children in phase 2B study. So hopefully by next year, if this drug truly works, and we have the ability to replace prednisone, and you don't have to suffer these many side effects of it.
How exactly am I going to follow replacing prednisone? Should I just pass and keep going? Hi, everybody. I'm Christina Charles. I'm from UCLA Medical Center. I am a rheumatologist. It's a bit of a sad story how I got interested in myositis several years ago. I met 2 young women, one in her 30s, one in her 40s, both with a fair number of young children, who had been referred to UCLA as a transplant center for evaluation of lung transplant. Both of them had dermatomyositis. One had somewhat subtle rashes that were missed over a period of 10 years. And she was told she had recurrent viral pneumonias, asthma, et cetera, and by the time she came to UCLA, she had end-stage fibrosis in her lung. The other one had more profound rashes, but had an aggressive course of her lung disease, and again, wasn't treated adequately initially. The sad story is neither one of them are with us today. The good part of the story is it made me decide that while nobody at UCLA had any experience or a specialty per se in myositis, that perhaps that's what I should do. We had great physicians in scleroderma, programs in lupus and rheumatoid arthritis. And so after that, I started seeing patients with myositis. I didn't have anyone to guide me per se, but I figured it out. Today, I'm very happy to tell you that I have a large number of patients with severe myositis, including severe lung disease, and I have just had a lot of successes over the years that keep me going, and that I really thank my lucky stars that I've met a lot of you and have been able to help you. So thank you very much.
Thank you. Good morning. My name is Stevie Eric. I'm a rheumatologist, an adult rheumatologist at the Mayo Clinic. My office is right next door to Dr. Ernst's, so we talk about patients a lot. I got into seeing myositis patients when I was a fellow, more than 35 years ago. I was assigned to, started out in a virology lab. So I was doing basic science research with a person who's a virologist, and we started looking at interferon, which was sort of a backwaters at the time, but now is a hot item. But that wasn't going anywhere, and somebody else in the lab had been working on an animal model of myositis using a particular virus in mice. So I started with myositis in mice and did that for a number of years. But I've been at Mayo now for 19, almost 20 years, and there I spend my time seeing patients. I'm just a simple country rheumatologist, to quote Leon Jaworski, out in the sticks, but get to see a lot of patients. I don't have a research lab any longer, but we do clinical trials. I get to collaborate with people who have labs and want samples, and so it's been fun, and I get a lot of joy and encouragement from helping people with myositis. Thank you for being here.
Good morning. My name is Rohit Agarwal. I'm a rheumatologist at University of Pittsburgh. I got interested in myositis for 3 reasons. As soon as I was done with my fellowship in rheumatology from Chicago, I wanted to work on a complex disease. I always knew I wanted to go in research, but I wanted to work in a research in rheumatology with a complex disease. And there are many complex diseases in rheumatology, and I had not selected by then myositis. The second reason was my wife. I knew that I had to move back to Pittsburgh because my wife was doing pathology residency at that point. And the third reason is my mentor, Dr. Otis, who has done myositis research for like 3 decades. And I mean, he's a great man. And I met him and I knew that these 3 things aligned together. My want to do or work in a complex disease, my wife being in Pittsburgh, so I had to move back to Pittsburgh, and I found this mentor. Those were the 3 reasons that aligned for me to start working in myositis. And since I have started working in myositis, I love every part of it. I love all my patients. I just enjoy what I do, trying to find answers to this complex disease. So that's the reason. It wasn't myositis to begin with, but I went into myositis and loved every part of it. So I want to take this opportunity that I have to ask you a few questions, if you don't mind. My first question to all of you is, how many of you are currently participating in clinical research? Can you, with a just show of hands? Okay, all right, thank you. How many of you are willing to participate in clinical research? Excellent, excellent, that's great. Okay. How many of you have smartphone? All right, that's good, thank you. How many of you are willing to participate in clinical research using your smartphone? Excellent, okay. And the last question is, how many of you are willing to participate in a clinical trial where data is transmitted through your smartphone, where data is collected and is done through your smartphone, so you have no problems? Thank you very much. That's because I'm asking these questions because I want to move the research, the clinical research that we do in myositis to a very different level. I want to move it from the center or a doctor-based research that we currently do, and it's great that we've made a lot of progress, to actually patient-based research, basically taking research to patients' home and having easy access for patients to join research just sitting at their home. And that's what I want to do, and you can only do it using smartphone. And that's why I was asking these questions, that if you are willing to participate in clinical research and have a smartphone, there is no reason that each one of you can really participate in really meaningful clinical research just sitting at your home. Because all we want is input from you. You know, all we do, and even in clinic when you come to see us, we ask you several questions. We ask you your responses. That's all that the clinical research is. You know, we say, okay, what are the side effects are you having with this medicine? Did you benefit with this medicine or not? What are the new clinical features are you developing or not developing? You know, you have to give your blood, and you know, so there's a lot of clinical research can happen just from patients' homes, and that's the future direction I want to take. So thank you very much for answering those questions, because that really helps, your feedback really helps there. Thank you.
Good morning, everyone. My name is Helena Alexandersson, and I'm a physical therapist from Stockholm, Karolinska University Hospital. And when I graduated from physical therapy school, I was 100% sure I wanted to work in stroke rehab. But then I came to the Karolinska a couple of years later, and in clinical care, I worked together with Professor Ingrid Lundberg. And she cared for many of the myositis patients at the clinic, and she started to refer patients to me. And I started to look for literature. Is there anything out there about exercise or physical therapy for patients with myositis? And I discovered that there was almost nothing. And Ingrid Lundberg, she had a fairly young man who was diagnosed with polymyositis, I think, and she told him not to exercise, take it easy. But he was not obeying her instructions, so he came in to her office and started to do push-ups. And so she said, "What have you been doing?" And he said, "I've been exercising." So together we wanted to challenge this notion that exercise was dangerous, because that was what was in the literature about 20 years ago. So together we have done a few exercise studies, and together with other studies, today I think we have a fairly solid evidence to say supporting that exercise is absolutely safe for everyone with myositis. And there is more evidence for effects of exercise in pollen dermatomyositis, where we have actually seen anti-inflammatory effects of exercise. And there are fewer studies in IBM, so that's an area of research that is really important. But today we see exercise as a medicine, as an additional medicine to all the drugs you're taking. So for me, it's really inspiring to come here. It's my 4th year to meet all of you and hear your stories and experiences of exercise. So I want to say thank you. I learn a lot from you.
Hello everybody. I'm the newcomer in this advisory board. My name is Olivia Valliere. I'm coming from Paris, France. I'm a clinical immunologist. I started my PhD working on the immunology of HIV disease, something very far from myositis, but I get a position 20 years ago in one hospital where a large cohort of myositis patients were existing, and we decided, my former boss and I, to mount in France a myositis center and also to mount a myositis network in France. So I share my time now between the Department of Neurology, where I have a clinic, and the Department of Clinical Immunology, but also in research, because we mount also a group of research. And we have different programs ongoing. For instance, we have basic research on the physiopathogenesis of the different autoantibodies, in particular anti-SRP or anti-MDA5 autoantibodies. We have also some research on clinical outcomes, and in particular in some devices, small devices such as a watch that can measure over time the activity during your real life, and to see if that is a good outcome measure for future clinical trials. And regarding clinical trials, we mount different trials, and we just finished one clinical trial for IBM using rapamycin against placebo. And you know that we have some results. So that's it.
Good morning. My name is Reid. I am a pediatric rheumatologist, so probably a unique one on the board for that because of that. You know, you've been hearing stories about how individuals got interested in doing research and focusing on myositis, and one of the things I want to mention is that this often happens during our training, whether we're a resident or fellow, and I really think it's a key time to try and encourage individuals to be involved with this very important work. Mine was similar to others in that I was a fellow in a very busy juvenile myositis clinic in Chicago, and really just was so fascinated with understanding why did these children who were running and playing 1 week, and 2 weeks later they couldn't get off the floor, they couldn't brush their hair, and the children didn't know what was happening to them. You know, children are always so positive about everything. They just want to be normal and play as we do as adults. We just want to be normal like everyone else. So this really fascinated me in trying to understand, you know, what was this condition, why was it happening to these individuals, and what can we do about it? And that's what I've spent about the last 25 years or so with a laboratory as well as a large clinical practice seeing patients with myositis. I started out with really looking at the immune response genes that we thought were related to the disease. You know, why, you know, who has this condition and what are the genes that are related to it? and then moved in my work into really looking at the inflammatory cells that are affected in the tissues. What cells are there and what are the cells producing? What kind of proteins are they making? By using many of these proteins and after identifying them, we moved our work into really trying to use these as markers of disease. So focusing on what are the markers that can tell us that somebody's disease maybe is active. As you recognize, often you feel better, but you're not quite sure, is the disease really controlled or not? And we were trying to find better ways to help us identify that and be able to predict that disease was controlled, but also if you're having a flare or worsening of disease. That work also continued into more what I'm doing at present day, which is really taking information on patients on a large scale. So looking at patients across North America who have, let's say, juvenile myositis, we've done this in adult myositis as well, and trying to look at the features that can help me predict subsets of disease, predict if someone's going to develop a complication, if they're going to respond to certain therapies. And that's really what I've been involved with at the present time. And I just want to make a sort of a pitch to say one of the reasons I think we've been able to be successful, and I hope to have future success in this, particularly in the pediatric realm, is that we've collaborated. There's been people across North America and now across the world that are collaborating to share information on patients, share potential if we do some biological samples, we're doing some assays in the lab, to share that information globally so we can have a large number of patients, so thousands of patients that we can then study and really look at, okay, which patients are going to respond to what medicine, so I don't have to expose everybody to the same amount of medicines. Who's going to have complications such as lung disease or calcinosis? So how can we tell at the start better what someone's path is going to be? So, thank you.
So now is the time that we will take questions from you all. And we always have so many questions and everybody's question is so burning. We'd like to get as many of those questions answered as possible. And in order to do that, we need to make our questions succinct, short. So just to remind everyone, a question is a sentence that ends in a question mark. Okay? So please save your personal stories for another time. These guys will all be here for the rest of the day. You'll be able to find them another time. So where will we start?
Good morning. Good morning. I wanted to ask the physical therapist from Stockholm, is it?
Yes.
Good morning. I wanted to ask you the confusion about physical therapy, whether it should be lots of stress and resistance versus less resistance, whether it should be every day or every other day. I'd just like to be clear with that on whether, here's the question, whether or not our IBM patients should be doing more stressful exercises followed by great rest, or they should just, or whatever, what should be the procedure generally? Thank you.
Thank you for that question. From what we know today, from both studies and clinical experience, indicate that if you have IBM, you should exercise shorter sessions, but more often. So the program, the home exercise program, which was developed and evaluated in a study in Australia about 10 years ago, is safe, and you should do one session in the morning perhaps, and then one session in the afternoon. And it's very important that you start on the right level, depending on what function and what strength you have at the present. So you should go in low, thinking, now I'm going to do exercises that might give me a moderate exertion. So you will be able to continue the rest of the day, not be, lying in bed next day. And then continue and stick to this program. So the study was for 16 weeks, so that's what we're kind of recommending. But after that, you can maybe stick to some home exercise program. You can do aquatic training, you can do walks, and slowly build up what you're doing. But you need to challenge your muscles. You need to have resistance. Otherwise, your muscle won't get stronger. Was that a good answer?
Yeah, are there genetic implications to myositis? In other words, should my children kind of keep an eye on this?
I'll take that one, since I mentioned it. So we know, and this is not in IBM particularly, but in the other forms of inflammatory myositis, there are immune response genes that are more highly associated with individuals who get myositis. They're the same genes that are seen in other autoimmune diseases, and the thought is that it just makes your immune system more active and more reactive. So the answer about your children is your children are inheriting some of these genes from you. However, it by no means means that they will get an autoimmune disease. And so we don't particularly recommend that anyone get monitored, because many people who don't get autoimmune diseases are running around with these genes as well.
Morning. For the two doctors from Johns Hopkins, where I'm actually trying to get into, question is the center seeing a lot of patients with combinations of DLE and SLE, any type of combinations with those type of disease?
So are we seeing patients who have sort of overlap myositis with other autoimmune diseases? Absolutely. And we see patients who have lupus and myositis overlap and scleroderma myositis overlap, and actually we're particularly interested in those patients. And there's a rheumatologist at Hopkins whose name is Julie Pack, who together we've been really focusing on trying to understand myopathy in patients who have scleroderma. And then Eleni Tiniakou is another rheumatologist at Hopkins, and she's particularly interested in lupus and myositis overlap patients. So we actually often will collaborate with in rheumatology, the other sort of specialized centers. So if somebody has lupus and myositis, often they're followed jointly by a physician who's at the lupus center and a physician who's at the myositis center. So yeah, we're very interested in that.
Yeah, clinical trial BYM 338 was canceled by Novartis, but lots of data was recovered, and I wonder how that data can be used in the future.
I can comment on that. So even though it failed to meet its actual primary endpoint of 6-minute walk time, actually a number of the other results are somewhat encouraging. So for one, actual measurement of muscle mass actually improved with increasing dose of BYM 338. Also, in terms of actual patient-reported outcomes, or PROs, which are increasingly important in clinical trials, those who received the highest dose actually reported improvements in functioning relative to low dose and placebo. And the results of that clinical trial are currently being written up, and hopefully in the next 6 months or so will be published. My hope is that since Novartis is actually trying this drug with a number of other diseases, that if eventually it is approved for an indication that in IBM, given the results of this clinical trial, showing some benefit, that perhaps in combination with other treatments, maybe arimoclomol, maybe immunosuppressive drugs, that number one, additional clinical trials will be done, and number two, that eventually perhaps if it is proven in other studies of other diseases to be effective, that insurance companies perhaps may be persuaded to actually cover either bimagrumab, or I would also say there's a number of other actual companies that are developing the same class of medications, these myostatin inhibitors.
Speaking on data collection and getting input from patients, is there currently a registry in place that we can participate in and help you with your research?
Go ahead, you can answer.
Yeah, so what I'm doing right now is developing a registry, an online registry, which is can be online through internet or an app-based registry. It's not currently available, but I'm hoping in 6 months we will have that registry available online that any patient can join.
There is a registry for children that's North American that most children with myositis get put into. But that was the groups all working together, and I'm not aware that there's anything on the adult side like that.
No, I don't think on adult side currently we have any online registry where you can join. They are center-based registries. Like we have a huge center, we have more than 1,000, 2,000 patients who come and join our registry, but for that you have to be part of that center. You have to go to a center, sign a consent form. You cannot do that if you have never seen us. What I'm trying to do is to be able to expand it to anybody who, whether have seen me or not, or seen other doctors or not, they can be part of the research and really contribute. And remember, every small data that you contribute in collectively, all of you becomes a very strong data.
Hi, thank you all for being here, by the way. I'd really like to understand whatever there is out there about cause and also how to prevent relapse, specifically related to DM, but anything you know.
Well, in terms of the first part of that, I don't think we know still the cause. I think viral infection and a lot of viral related genes have been implicated in dermatomyositis in particular, but at this point I still don't think we have the magic bullet in terms of what causes the disease. In terms of relapse, that's an easier question. My experience, the most common cause for relapse is either number one, not enough disease treatment initially, or that treatment much more commonly being tapered off too quickly. In my experience, patients with DM in particular can do extremely well as long as enough medication is used to control the disease fully, and that doesn't mean so that you feel kind of okay, it means so that you feel pretty close to how you were before. They can't bring back the muscle tissue that you lost, although exercise is fantastic, and we've heard a lot about that in terms of making you stronger. But the biggest thing that you can do is not too quickly taper off your medications. And I know we all hate them, but the patients that I've had that have done just tremendously well over the years, gotten to a remission and then stayed that way. And we didn't take off all the medications because they were doing so great. We kept them well for months to even years, and then slowly peeled off the medications. That's most important.
One more.
Hello.
Wait.
So as for cause, I agree, we don't know. There have been some epidemiologic data, so this isn't to say that for any individual, but if you look at large groups, smoking cigarettes is one that probably has been linked. It's very clearly linked to rheumatoid arthritis and some other autoimmune diseases, and there is some evidence for myositis as well. And the other is for flares. For some patients with dermatomyositis, UV light exposure, sun exposure, can make some patients flare.
Hello.
Good morning. You've talked about the juvenile. What I want to know, the other end of the spectrum, how much has age been considered in the onset of the disease, the treatment of the disease, and the outcome?
So we have been interested in age and how it plays a role in how people do with different forms of autoimmune muscle disease. So this is not really for IBM, but we've looked at our patients with most closely with necrotizing myopathies, and we had always read that the older you are, the worse that you do. But what we actually found out were that for patients with the necrotizing myopathies, the older people were when they developed the disease, actually the better they did and the better they responded to therapy. And it was our younger patients who actually were the most difficult patients to treat and were the least likely to respond to therapy. We have no real idea why that is. So it's something that we're really interested in. But that just applies to, again, that one very specific form of the specific kind of myositis. In general, older people are more likely to have associated malignancy, and so those patients might not do as well as other patients, but it's definitely something that we need to learn a lot more about.
So maybe I can comment about inclusion body myositis. So that is a disease of aging. In fact, the greatest risk factor for getting inclusion body myositis is being over the age of 50. And so that is a clearly age-associated disorder. Why that happens in older individuals is unclear. There are some genetic forms of inclusion body myopathy, so not an itis. Itis means inflammation, and apathy means there's no inflammation. And so there are some suggestions that perhaps people are susceptible to age-associated weakness. There definitely are scenarios where patients who have hereditary forms of inclusion body myopathy look very, very similar to inclusion body myositis. But why that disease happens as we get older is still a bit unclear.
Is there a difference specifically with hereditary, genetic, talking about IBM, as far as approach for treatment? Does it make a difference whether it's genetic or not? So can genetic or hereditary be treated, and is it looked at the same?
So let me make sure I understand the question. So you're asking the distinction between hereditary inclusion body myopathies and inclusion body myositis, and whether there are different treatment approaches for those two?
When you do research or testing for whether it's a myopathy or myositis, does it make any difference if it's when it's genetic? As far as treatment, does treatment vary, it being genetic or not?
So there's a huge distinction between the two, and it's important to make sure that if there's some indication that you might have a hereditary form, whether you have a family history or whether there were some features on muscle biopsy that did not show evidence of inflammation, or whether you had onset of inclusion body myopathy or myositis at an age earlier than 45, you should start thinking perhaps that it's hereditary, and it has implications for your family, but it also probably does have implications for therapeutic trials. we want to make sure that we make homogeneous sets of patients in clinical trials. And so someone with a hereditary form of inclusion body myopathy would likely not be able to participate in an inclusion body myositis trial. And so I'm making the distinction between the inflammatory form and the non-inflammatory form. There are also clinical trials out there for hereditary forms of inclusion body myopathy, which would not be appropriate for patients with inclusion body myositis.
Hi, I have DM, and I've met a lot of patients here who have calcinosis. I just wanted to know if there were any medications that cause it, and if there's any known ways to treat it other than surgery, because I heard with surgery, a lot of the times it grows back.
So I probably have a great deal of experience with calcinosis because in the pediatric population you do see a lot of calcinosis. And I have to say that we don't have a great treatment itself. However, one of the things is people recognize that often when calcinosis is evolving and continuing to developing, often it's because you have some subtle ongoing disease in the muscle that really needs to get treated. In addition, people have been successful in a very small number of patients, especially when it's really severe, in adding some of the new biologic agents to the treatment, such as the anti-TNF drug, such as Enbrel, has been found in some subpopulations in some patients to really help. And also there's another biologic, the anti-CTLA-4, sorry, Actemra? Abatacept, sorry, Abatacept. I always get the name wrong. And it's also in some trials with very small number of pediatric patients have been found to really help improve the calcinosis. The other things over time that we sometimes use are something called bisphosphonates, which are one of the agents that helps build up your bones. It's thought to help in some patients, but really those studies, it's varied. Some patients it helps in, some patients it doesn't help in. So the bottom line answer is probably not a lot. You guys are more in the adult realm, might have some more information on the adults.
I can comment as well. If the area of calcinosis is small enough, just subcutaneous, there's a topical formula that we compound. At Mayo, I work with a dermatologist. It's called sodium thiosulfate, and it's compounded in zinc oxide. And if you have just a small area, and if you use it over a couple of months, it helps to dissolve the hard calcium underneath the skin. And we're going to report on that in the next couple of months or so and publish that.
Yeah, and I'll just second that. I've used the topical thiosulfate cream with success in several of my patients at this point. Not the huge, large calcium deposits, but the smaller ones. I'll also second what Dr. Reid said about active disease. I've had some patients over the years with open weeping lesions with the calcium coming out, and those situations, controlling the disease better has allowed those lesions to heal. And in terms of Dr. Reid's comment about the abatacept, there is an ongoing active clinical trial in adults with dermatomyositis for abatacept.
Can I ask my adult colleagues whether any of them have used or had success with TNF inhibitors for calcinosis? Because I think it might underscore sort of the difference between juvenile disease and adult disease.
Yeah, we don't use anti-TNF in adults at all because we don't think this is helpful in adults, and that's what the difference in juvenile might be.
In the calcinosis, because in children you get a lot more vascular inflammation, which it feels like that helps calm it. And I would imagine only in the subset adults that would have that would you consider it, right?
I agree with my colleagues, the adult rheumatologists. TNF alpha does not work very well for adult myositis patients.
I agree as well.
First of all, thank you for doing the research, being in the area of research that you are, and for being here. I would like to address the doctor from Kansas City. Are you involved in that clinical trial that we hear about, but not very much? Could you tell us about that? Thank you.
It's about time you asked.
So, thank you for asking this question. It comes at the perfect time. Last year, we talked a little bit about where we're at, and this has been a long work in progress in trying to get a clinical trial set up for being the right design, the right everything that goes along with it to be properly done. So we've been working hard towards that goal in the last more than a year, actually 2.5 years. And before then, there were years of work going for probably now, if I think back, this is now 10 years working on this project in some way, shape, or form. So some of you have been really tracking our activity, and I want you to continue doing that through the clinicaltrials.gov website that kind of gives an update about what's available in the way of information that I can share with you. But for some of you that have not looked at it in the last week or two, that have IBM, you may want to know that the study finally started. The one study that I'm leading, which is the study of arimoclomol, a chaperone inducer in people with IBM. It's a placebo-controlled study. It's a multi-center study. There'll be 150 people with IBM enrolled in it to receive either the placebo pill or the arimoclomol experimental molecule. We're doing this study because we do not know if this drug will work in IBM, but we're trying to see if it does. While I would like to tell you that I'm looking at a drug that will improve the strength in IBM, that's not what the goal of the study is, and that don't pretend to be that the goal of the study either. The goal of the study is to show if this chaperone that will be expressed in stressed muscles like IBM muscles will help reduce the rate of decline that one that has IBM. In other words, will it buy you more good days, years, month? We don't know the answer to that. So we're not trying like the bimagrumab to grow muscle and improve your 6-minute walk distance covered. We're looking at an instrument called the Inclusion Body Myositis Functional Rating Scale and trying to see if this instrument will show a different rate of decline favoring either, hopefully, the chaperone, but we don't know that. We're trying to answer that question through this study. It's a long study. People that commit to doing this study will be in it for 20 months. This started, meaning this is the start line. In the next 3-4 years, all patients will be enrolled. We hope that we will have some data to share with you as to what the outcome of this study is. You're welcome.
Over here.
My experience in listening to other people here and talking is I've learned that there are many incidents of non-diagnosis for years or misdiagnosis. And then for those rheumatologists, lots of varying treatments, methods. And one of the things I've been surprised here is learning about the autoantibodies, and I'm sure I'm not sure, but I doubt my rheumatologist maybe knows about that because he's never mentioned it to me. And I've actually researched tests that I suggested he do, which he added to my regimen. Now I can find my autoantibodies through a drug trial I was on, and the results can be released. So basically my question is and I ran across somebody here who in a presentation showed their results from their tests from their rheumatologist, and the autoantibodies were on it. So I'm just wondering if there's some way to have a protocol for physicians, rheumatologists, and others to use to kind of standardize this
treatment and diagnosis and treatment of these diseases somehow.
So I'm going to take that. So first of all, this is absolutely clear. I mean, many centers and a lot of research has shown that autoantibodies are absolutely important in myositis. They're important in diagnosis, it helps. Second thing, it really helps us, really defines a unique clinical features that a particular patient are going to have or currently have, which is very important. So if I know what antibody you have, I can tell what are the clinical features you may have. For example, one kind of antibody like JO1, those patients may have interstitial lung disease, pulmonary fibrosis. So I will look for it as a physician. Or if you have anti-SRP antibody, then I know you're going to have a bad muscle disease, so I will be more aggressive in treating it. Okay? So that's the second thing. The third thing it really helps is deciding what treatment options should we give to those patients. For example, if I have a patient with antisynthetase syndrome or JO1 antibody or anti-PL7 or 12, I'm more likely to progress them to a drug called rituximab as compared to if I see a patient without that antibody. So it also helps us to decide treatment. So for various reasons, autoantibodies are absolutely important. The second part of your question is the standardization. That's where we are not good at, okay? There are many labs that are offering myositis panel, myositis autoantibody panels, and they have various variability in their results. So they have a lot of false positivity and false negativity, which means, you know, they were not able to detect it or they were able to detect something that wasn't there, which is a real problem in our field. And we discuss amongst ourselves as well that what should we do to standardize it the best as we can. And we haven't really found a great answer to that question, but I agree, we do need to standardize it. There are some labs that are more reliable, and there are some labs that are not very reliable. So I don't know the answer to the question, but the need is definitely there to have it a better standardization of autoantibodies.
We'll chime in one other thing. I think that the question of standardization, I heard, was also to standardization of care, rather than standardization of the laboratory tests, or in addition to that, which is a difficult situation dictating to individual physicians how they should care for individual patients. And organizations try to get around this or help by setting up guidelines. So there are guidelines that the American College of Rheumatology has regarding the approach to treatment of rheumatoid arthritis, diagnosis of this, that, or the other. There aren't guidelines around myositis, I think because it's a relatively rarer condition than some of these other things. But it is a direction that organizations to go, to say, based on the available evidence, and all of this is evidence-based, what's been published, what do we know that works, we would recommend that this, that, or the other get done, and it is sort of various degrees of affirmation about how much to recommend. But that is an issue. Should everybody who has myositis have antibodies sent? You know, it gets to be a financial question. There are a lot of things that go into it.
Can I add? Oh, go ahead.
Okay. No, I'll just make a short comment about, not about the antibodies, but you mentioned about being misdiagnosed or not sure if you're getting the right care and that sort of thing. And I have to say, most physicians that I have dealt with over the last 20 plus years now really went into this field of medicine to do good and care about people. That being said, myositis is a rare disease. So a lot of times you see your local rheumatologist, it's not their fault that they haven't had the exposure and don't quite know how to treat you. I have worked effectively with a lot of very good local rheumatologists to kind of guide the care. So I would just encourage everybody, if you're having questions or you're not feeling quite as good as you can, and most of you have gotten here, so you've already made it, but going to a bigger center and getting a second opinion, I think, is always going to be worth it. And all of us have had that happen, are more than willing to help guide with a local rheumatologist who then learns and can treat you even better.
I also just want to make one comment around the guidelines that we mentioned. If any of you have had onset of disease in the younger age periods, under 18, there are guidelines for how to treat juvenile myositis, and there are international guidelines that have been set up, giving multiple options and how to make changes if you're having changes in your disease activity. There's also minimal, we call it minimal evaluation criteria that have been established, which actually mention these are the things you should be doing for patients at the initial evaluation and follow-up evaluation.
I just wanted to point out also that this has been a troubling issue to a lot of us. I mean, you can go beyond individual expertise. Sometimes experts disagree. You can go to one center listed on the TMA website and they'll tell you one thing, and you might go to another. And the reason behind it is that this has been not only a rare disease, it's been challenging. One of the efforts that Dr. Lundberg from Sweden has led is the International Myositis Classification Criteria Project, and she's published that work that she's done. There were sites across the world, Japan, US, South America, Europe, any country that could participated in that project. But the bottom line, even if you look at these classification criteria, they leave some to desire. There's always the 5% of the patients that will fall either in this group or that group. So it gets to be a little bit of an expert judgment call. Thank you.
Hello, thank you. Thank you for your presence. My question is about cancer being, okay, my mom had Hodgkin's lymphoma, stage 4 Hodgkin's lymphoma, went through chemotherapy, was in full remission. So I'm wondering if there's any research or evidence that chemotherapy accelerates the onset of IBM.
I don't think there's any evidence of that. Really, there's no clear correlations between malignancy and inclusion body myositis.
Oh, hi there. My wife has IBM, and she sought out a number of alternative therapies to deal with pain and other issues. She's tried acupuncture and medical marijuana. Is there any evidence that this type of additional treatment is either helpful or hurtful to autoimmune diseases?
So short answer is no. What I would say though is a lot of different alternative treatments. So anything you can imagine, acupuncture, massage. In my experience, a number of patients do absolutely swear by different so-called alternative therapies. Now, whether it is a placebo effect or not is always a question. My own opinion is if it's safe, inexpensive, and it's something that you're interested in trying, even if it is placebo effect, we know placebo effect is real. We know how it works in the brain, and so why not try it? Others may have different opinions.
I would like to add to that there is some evidence that acupuncture can have a positive effect in rheumatoid arthritis, which is another autoimmune disease. But I mean, there is a strong indication for acupuncture to treat pain. So still, if it doesn't matter what autoimmune disease you have, if you have a lot of pain related maybe to joint damage, so I would definitely say that acupuncture is something worth trying.
What is the role, safety profile and effectiveness of biologics in the treatment of specifically dermatomyositis?
Okay. So
The role of biologics, I think we are learning, to be honest. I mean, I don't think we know for sure. You heard from Dr. Reid that anti-TNF might be helpful in juvenile myositis. What we have learned is rituximab is really helpful if you have a certain type of antibody called anti-synthetase antibody, Jo1 antibody. So we have seen that is helpful, and also helpful in interstitial lung disease, if you have myositis-associated interstitial lung disease. But beyond that, there are various clinical trials that are being done, one on abatacept, which is being done in calcinosis, okay, thank you. In an adult DM and PM, there are other clinical trials that are being done with abatacept, for example, which is a biological agent and is being studied, and we don't know the results of clinical, it hasn't even started. So I think we're learning, and I think in future you're going to see a lot of biological agents basically trying to target different aspects of the disease, and I'm hoping that in future one of the biologics will really come out to be as a key treatment of dermatomyositis, polymyositis at least.
I have a question about possible new areas that IBM might be affecting. And I'm wondering if any one of you have seen this in any of your practices. Is there any, does anybody up there have experience with patients having IBM affecting their mouth or their tongue or this area?
I've seen actually IBM affecting the strength of tongue motion. You know, we usually, when you test that in the clinic, we have people poke their tongue through their cheek. I've seen that as a problem. I've also rarely seen an IBM patient where I was in disbelief. I thought it should be something else, where their ability to keep their jaw closed, clench your jaw tight, and you ask them and you pull against them, was weakened. So these are the types of observations that I've seen in the clinic in the way of IBM symptoms. In the case of jaw, it resulted in difficulty chewing in that patient. Yes. Right. And so they can't hear the question. I'm just going to repeat it. She experiences tongue swelling with IBM. I'm going to say sometimes when patients tell me, you know, it's tongue swelling, is it actually a swollen tongue or a tongue that's not moving very well? And that comes back to the issue of how strong is the tongue moving inside the oral cavity, which can be easily tested and distinguished from tongue actual swelling.
Is there any evidence that someone treated for lupus and rheumatoid arthritis and related diseases who later develops IBM might have had earlier onset or more severe IBM because of the use of immune suppressing drugs?
I mean, it's a very interesting question. I mean, and we've seen patients who have other autoimmune diseases who develop inclusion body myositis, and I don't think we really understand what that means. We don't understand if it's whether the underlying autoimmune disease makes you more susceptible to inclusion body myositis or whether treatments might contribute to that. It seems to be relatively rare, and it's probably giving us a clue about the disease, but I don't think we understand it. I don't know if anyone else has anything to add.
The only thing I will add is, I mean, I've treated a lot of patients with RA and lupus, and I've never seen anybody with RA and lupus treatment, post-treatment developing IBM. I don't have any patient with IBM who has or previously was diagnosed with lupus or RA and was treated and then developed IBM. I'm probably interested in knowing other people.
Sjogren's is the one that we see.
Yes.
You know.
That's what Sjogren, yes, is frequently associated with IBM, and sometimes also sarcoidosis.
Can I just add that I know one in particular who's had lupus and RA for about 20 years and was diagnosed with IBM about 3 weeks ago.
Thank you all for being here. I had a question, a follow-up question for Dr. De Marchi regarding the clinical trial. I know a number of us have been interested in being involved in that trial and wanted to know, when you say it's multi-centered, where some of the other centers might be and how best to get involved in that clinical trial.
Thank you for this question. So there will be one center in the United Kingdom for some of you that are visiting from far overseas. There'll be the lead site in the U.S. is University of Kansas, as well as 10 additional other sites distributed geographically across the U.S. While I would like to tell you the sites are A, B, C, D, and E and be specific about them, the reason I can't be specific is certain things need to happen. And those certain things are things like contracts with sites being signed and going through the review process through the ethics committee, also known as institutional review board. All of that is ongoing, but as it does get updated for the next site being activated and the next site being activated, pay attention to clinicaltrials.gov. We'll be frequently updating it so that people with IBM not only have the site name that's closer up to you, but the contact information of the person at that site. This way you have this direct access.
And let me just add that anybody can go to clinicaltrials.gov and enter myositis and find whatever clinical trials are available, are recruiting, have completed, or whatever. You can find that information online. Right here.
I would like to ask what the current thinking is on the panel about the use of statins. Like a lot of people in here, I was on statins for many years before I developed symptoms, and for many more years until I got a proper IBM diagnosis. And I was worse on statins. I've been better since I've been off the last 4 years. My rheumatologist wants to, my cardiologist wants to start the new injectable cholesterol lowering drug, once a month injections. I can't think of the name of it right now, and I've been approved through my insurance, but my rheumatologist is not sure about that because it's a new drug, and even though it acts differently than statins, supposedly it's new. But I have pretty bad high cholesterol and heart disease, so I'd like to know what the thinking is about the continued use of statins or this other new injectable drug for people who are at high risk for heart disease with myositis.
You missed our session on the heart the other day. We had a whole chat on this subject. It's a very important topic, not to make light of it all. Statins are not for everybody, and even patients without myositis, there are a lot of patients who don't tolerate statins, from myalgia all the way up to rhabdomyolysis with CKs in the 15,000. So that's point one. They're not for everybody, for patients with myositis and without myositis. Certainly if you have myositis associated with a necrotizing form with the HMG-CR antibody Dr. Mammon developed, you cannot take statins. That being said, heart disease is also a real problem. And, you know, quite frankly, people die of heart attacks and strokes quite commonly in this country. So you can't ignore the hypercholesterolemia. The new drug you're referring to, I think, is a PCSK9 inhibitor, which is a monoclonal antibody very targeted to stop the LDL pathway through the liver. There is no data that I know of, particularly in patients with myositis yet. There is a lot of fear around cholesterol and statins in myositis, but I don't think your doctors have any data to suggest that there's a reason you can't try it. It's a very targeted therapy in contrast to statins that have a lot of other effects. So, you know, I would urge you to still keep that high cholesterol high in your mind if you have heart disease, because you need to treat it. Andy may have some other information.
No, I mean, I think that's a very good answer. In general, we don't think that most myositis patients, including inclusion body myositis patients, need to avoid statins. It's really just the subgroup who have the statin-triggered autoimmune muscle disease where we're really especially cautious about restarting a statin, and we think hard about whether to start other cholesterol-lowering medications. That being said, I would echo what you said. Some people, whether they have inclusion body myositis or not, are statin intolerant, and may not tolerate statins, but may tolerate this new class of drugs. But I wouldn't suspect that it's going to permanently alter the way the inclusion body myositis is going.
My question is for Dr. Alexanderson. I'm right here. I'm over here.
Oh, there you go.
Thank you. With all the controversy over the years about exercise, you know, we really sat back and did nothing for my husband's IBM, and now we feel like we've lost a lot of time. And so, two questions, but they both have question marks. Is there a way to catch up some of that time? And number two, you had mentioned a study that included an exercise protocol from Australia. Do we have access to that protocol so we could maybe start that program when we get home tomorrow?
Answering your second question first, that home exercise program is up on the website. Linda, is it going to be under presentations from this year or last year?
It's on the website now.
Oh, okay, so it's called Home Exercise Program for IBM. And you can definitely go home and start tomorrow. And for the first question, I mean, IBM affects different muscle groups, right? Specific muscle groups. So if you had a disease for a long time, there is a risk that you have too much muscle damage. However, other muscle groups that are less affected, you have I would say, a short chance to improve the function in those and be able to compensate. And I would say, until you have tried it, it's definitely worth trying. And I think one important point is that there is an increased chance that your husband will maintain the function that he does have now.
So just to let you know, the best way to find it on the website is to do a search for exercise IBM.
Okay. My question is, does anyone on the panel have patients that might have the eye that's affected with flare-ups and polymyositis, and if so, what medications are they taking for preventative as well as in the inset, other than prednisone?
I think not.
I know it's extremely rare, but I've been to different eye institutions and different, I'm from California, and I get the eye irritation and blindness when I get a flare-up, along with other things, but no one seems to have a medical cure for that or treatments, and I'm just wondering, has anyone else experienced this in their panel?
So I think we've talked among a couple of us here that eye inflammation in myositis can occur, but that it's a rare occurrence, and you always have to ask, is it really because there's overlap with some other disease? Does this relate to Sjogren's syndrome, or is it overlap with some form of vasculitis? That because we see patients with one autoimmune disease have another, and so the eye inflammations, this iritis, also known as uveitis or scleritis, episcleritis, are things that happen with other autoimmune diseases. So I wouldn't think it's impossible, but it's not a regular thing seen with myositis. And treatment is the same sort of things. Is it steroids or immune suppressing drugs? And they might start with topical steroids as drops.
So sorry. This will be our last question. I'm sorry. We're coming to an end. Go ahead, back. Joe?
Oh, many of us suffer with some form of chronic fatigue during our duration or battle with myositis. I just wondered, is there a study on fatigue with myositis, and is there some place we could go to help us overcome the fatigue?
Well, if I got your question, can you repeat your question again? What to do about fatigue? Yeah.
Many of us suffer from chronic fatigue.
Okay, yeah.
And is there a study on chronic fatigue with myositis? And if there is there some place we can go to help us overcome the fatigue or deal better with it?
Thank you. What we have done interviews with patients with myositis, both here at the TMA, I think a couple of years ago, and in Sweden, in South Korea, and they all talk about fatigue. So it seems to be a really common and a severe problem. And I think, Joe, you're doing very much already because you're very physically active. That seems to be able to reduce fatigue. Some strategies that patients have been talking about in the interviews has been, pacing your day, trying to find a balance between activity and resting, and being outdoors, just getting a lot of oxygen, is another strategy that patients have described for us. In terms of medical treatment, does anyone have anything to? I mean, there are data for example, in rheumatoid arthritis that if you reduce the inflammation, for example, with a biologic treatment, they have seen that fatigue gets better. But I don't know if we have seen that in any myositis study.
It's interesting. I think as somebody who sees a lot of myositis patients, I think we've become increasingly aware that fatigue is one of the major unexplored areas in myositis. I mean, I have patients who who I originally saw when they were very weak, and we've treated them and their strength is back to normal and their CK is low, and I'm like patting myself on the back about what a great job I've done. And but they are just really still disabled by fatigue. I mean, I've known people who've had to really stop working, even though by my usual criteria they seem to be doing well. So it's something that we really don't understand very well, and it's unclear to me how to treat it as an isolated thing. I think most of us don't increase immunosuppression, for example, if everything else seems to be going well, but people just have disabling fatigue. So it's a huge thing that I think we need to pay more attention to, but that we don't understand very well.
Well, I just wanted to make the comment that doing your exercises on the TMA side has given me a lot of my energy back, so it has helped with fatigue. I just wanted to bring up the fatigue subject.
Thank you. So I'd like to just thank you to, sorry,
one other comment. I agree with you, Andy. We did a trial on more than 60 patients with dermatomyositis and polymyositis, and in the patients that had cured, had normal strength, normal CK, most of them were either not able to go back to work at the end of the trial after 18 months, but also when we investigated that after 3 years. And it was not only fatigue.
Well, let's thank the panel for amazing, wonderful. Thank you. And before I invite Bob Goldberg to come up and give us some announcements, I'm going to invite the panel to go ahead and be dismissed. And okay.
We're dismissed. Okay. We're going to ask everybody here to stay seated, except for members of our medical advisory board. We're taking photos of them to put up on our website. We have sessions beginning at 11 o'clock where they're going to answer questions from each of you. So please remain seated. And I have a couple other announcements I would like to make. Dr. Asherman, who's chair of our medical advisory board, was not able to be here today because he's at the University of Miami. As you would understand, he's not able to make it to the West Coast right now. Also, Dr. Christina Charles, who's walking out right now, is leaving our medical advisory board. This is her last year of a 6-year term. Let's give her a round of applause, Christina. We have also invited Christina to come back on the medical advisory board. The way our bylaws are written, they can serve 6 consecutive years, then they need to step off so other people have a chance. And along those lines, we also this morning voted to increase the size of our medical advisory board to 24 members. We've added 4 new members who you're going to see if you come to the annual conference next year. You'll have a chance to meet them. A couple announcements for the remainder of today. I mentioned that there's silent auction items. We're going to close the silent auctions at 12:15. So if you're interested in those, make sure to find your way over there either before this next session or immediately afterward. We are going to have some drawings at lunch. I mentioned to you that if you go to the exhibitors and have at least 10 of them sign your exhibitor card, you'll be eligible for a drawing which will take place at lunch. The last thing is every year TMA does a 50-50 raffle at lunch as a way to raise money for the organization. There are going to be people selling tickets to you during the lunch. I do want you to know that one of the members of TMA has informed me that they are willing to match up to $4,000 of donations that are generated through the 50-50 raffle. So keep that in mind. You heard how research is an expensive proposition, and of course we are always looking to generate more funds that can be used for research into this disease. So with that, now that the medical advisory board is over there and out of here having their pictures taken, you two are welcome to get up and leave. So. Lunch is at 12:30, by the way.